is abnormal doesn't might be a coexistence can be told by flash ERG or multifocal ERG. Why so? And Dr. Jalali is going to tell us in her next talk. And she doesn't need any instruction for her.
Okay, it is so encouraging to have such a good audience. Thank you. And you're so I'm going to talk about which test to order, because many times people just order VP, ERG, EOG, multifocal ERG without understanding that, you know, what are we expecting. So as we know that we should have a pre-test probability of what we are expecting, otherwise we'll just go haywire. So the flash ERG reports, fortunately, can be put into one of these 6 or 7, you know, so it's not very difficult to interpret. So whenever we get the flash ERG, we can interpret it. Is it a rod cone type where rods are more affected than cones, or the opposite, or is it extinguished? And we have to differentiate extinguished from negative. Extinguished means you're not getting any responses in scotopic and photopic conditions, whereas negative, you will have the A wave, which means outer retina is healthy photoreceptors and inner retina is effective. And then you can have rod abnormal or cone abnormal, and you can have very rarely others. And then you have this multifocal ERG and pattern ERG for macular function, and VP, which checks both the macular and its derived optic nerve function. And then there are, of course, many special protocols where you can do the photopic negative response or the S-cone response, or you can do motion VP. And remember, the VP that we do in our ophthalmology doesn't rule out CNS lesion. It's only looking at the pre-chiasmal pathways. So you can have lesions in the CNS which will not be picked up by the way VP is done by ophthalmologists, whereas the VP which is done multi-channel by neurologists, that will pick up many more conditions. So just let us look at this diagram which is there. You don't have to copy anything. All this is available in AIOS CME series on the website. It is always also available in my chapter on modern ophthalmology and LC Datta, so just understand you don't have to copy anything. So this is what Graham Holder has given, that because we know whether the general retina is affected or the visual pathway is affected in the macula, or the optic nerve is affected. So it is a mathematical thing. You can see from one level to other, and you can deduce. And in this diagram, you can start from anywhere, depending on your clinical suspicion. You may start from flash ERG first, or you may start from pattern ERG first, or multifocal ERG, and you can deduce that which path of the pathway is affected. So the important thing before getting the test done is, what is the question that we are trying to ask? Are we trying to diagnose? Are we trying to prognosticate? Like, we already know the diagnosis, but the patient wants to know what is my prognosis. Or are we monitoring, like we do drug monitoring or toxic monitoring, or, you know, optic neuritis monitoring? Or are we looking at a patient of unexplained vision loss? Now, in an unexplained vision loss, our approach will be totally different from a patient where we already know what's the diagnosis. Or are we looking at the ischemic status? So I'm very fond of using ERG for checking whether this eye is ischemic or non-ischemic. Or are we looking at, I mean, my patient has a problem, I can see it, but is it a macula or is it an optic nerve? So I think before we order for the electrophysiology, we must, of course, do a comprehensive examination, have a very good detailed history of what the patient has. Recently, I had a patient who has absent ERG. And because patient has absent ERG and some RP changes in the retina, she was labeled as retinitis pigmentosa. Her history was not suggestive of RP, so I asked her, and she's been to all the doctors in this country. And she's been labeled as malingrer, she's been like a psychopath, she's been by top people in this country. And I think the main thing is nobody asked her history. So when she came with this diagnosis of RP in her hand and an absent ERG, I asked her only one question. I said, do you have night blindness? Immediately her husband jumped and said, nobody's asking us this question, but actually she has very severe aversion to light. She just cannot look at light. And when she started her problem 10 years back, that was her original symptom, that please switch off the lights. And this patient had azure, and she was labeled as RP just based on the ERG. So don't label anybody based on one test. Take the full history and do a comprehensive examination. Now suppose you are suspecting a dystrophy. Now in this patient you want to know, is there dystrophy or not? Is it a generalized dystrophy? Is it a localized dystrophy? Is it going to be progressive or non-progressive? Is it hereditary? Do I need to do genetic counseling? Or it is genetic but non-hereditary, like many of the Stargardts. They are genetic, but they don't pass from one person to the next family in most cases. Or are we trying to find out, like, how can I manage, like we said, you know, whether there is a CNVM or not? So it depends on what is the question. Whereas in a pediatric case, our question may be different. Is the child seeing? Is the child seeing well? Is there a visual impairment which is causing the delayed development, or is the developmental delay due to visual impairment? So our questions will change, our approach to the test will change. So of course you can have the phenotype, like there's a child who cannot see and he's eye poking and he has, you know, bilateral nystagmus and he has a brother who's also blind, okay, and he's hyperopic. You don't need to do an ERG. You make that clinical diagnosis of LCA. You may do ERG as an ancillary test, but you already have the diagnosis in your hand that, you know, this is very typical of LCA and only a couple of differential diagnoses will be there in a patient like this. So really you don't have to push for ERG. Same way, if a patient, especially in our South India, retinitis pigmentosa is so common. You know, they have field loss, it is autosomal recessive, they have night blindness. You don't need to do an ERG because you already have the diagnosis. But you may want to do a pattern ERG to know, like, you know, this patient has 20/50 vision, and really the patient wants to know, will I lose vision? When will I become blind? So if you do pattern ERG and it is showing the whole macular function is very poor, then this patient has a high risk of losing that 20/50 in next few years, as compared to any other patient which I will show, where the, you know, pattern ERG is very good. So again, we said in Best disease, although it is a clinical diagnosis, you only add to it with the EOG, but always do an ERG first to show that ERG is normal, and then only you know that it is a Best disease. So in RP, sometimes the condition is little difficult to diagnose. For example, you know, the retina may look near normal. There may be only subtle sign of mild change in color, or it may just be like there are few floaters and you may think this is a uveitis patient or pars planatis. So because there's so much phenotypic variation, in rare case, we need to do an ERG. But otherwise, in a typical RP, I don't need to do an ERG. Now here you can see another patient who clinically looks like a healthy macula, and when I do a pattern ERG, it is absolutely normal. So I know that, okay, I can tell this patient that, you know, for next 15, 20 years, you're not going to lose your central vision. So that's the importance. It is helping us to prognosticate this patient by looking at the macular function. Of course, you can look at the structure also, nosity, and you can look clinically also that this looks healthy, whereas this doesn't look healthy. So the negative ERG, of course, is useful for us in some cases where we are not able to see. So a child comes with night blindness, so is it CSNB or is it vitamin A deficiency? If there are no subtle signs of white or spots, so, you know, some things like that, some of the carcinoma-associated retinopathies. So there are various conditions which cause inner retinal dysfunction, and they can be picked up by this negative ERG. So here we have a patient who's an adult and comes with night blindness, so we are not, you know, sure whether he has a carcinoma-associated retinopathy or why he's having night blindness. So we do the ERG, it shows abnormality, we give vitamin A, everything comes back. And here you can see only the rod response was affected. The pattern ERG was normal and the cones were not affected. Of course, in late stages of vitamin A deficiency, the cones also get affected. In central RP, which people many times think that, you know, we shouldn't call it RP, but anyway, so here we will have a subnormal response. So that gives you very good clue to tell the patient that, you know, you are not going to go to PL vision. You're going to have a central scotoma. The central scotoma will become denser, but your peripheral vision is always going to be normal and the disease will never go to the next area. And this is because you are having a subnormal ERG and not an extinguished ERG, whereas in extinguished ERG, you know. Then of course, in some conditions like posterior microphthalmos, in enhanced S-cone syndrome. So these are the nyctalopia conditions that we want to rule out. So the same thing that you see in pattern ERG, you can also pick up by multifocal ERG, that the macula is quite healthy, and so this patient will survive his, you know, vision for a very long time. But here we have a patient who has come with 2200 vision in one eye, 20/20 in other eye, known case of RP, and patient wants to know, like, when you see this asymmetry, you think that, okay, RP has progressed in this eye, but you see the multifocal ERG is telling macula is perfectly normal. So this patient actually has an AION in that eye, and that is the cause of loss of vision and not the RP, because the RP area macular function is perfectly normal. So that's the question you want to ask. In sidrosis, you want to know, is it severe sidrosis where you have an extinguished ERG, or it is a localized sidrosis like this case? So in this case, when you remove the fawn body, the patient is going to live nicely in that eye. Whereas this eye, even if you get some vision for some years, ultimately this eye will get uveitis and, you know, die out. So these are the questions you want to know, that like how severe is the sidrosis and what is my long-term prognosis. So again, in Stargardts, patient wants to know, like, you know, am I going to worsen my vision? So you can see here there are no flecks, just central part. You do a multifocal ERG. It is telling you the function is abnormal here, but everything else is normal. So you can predict to this patient that your central scotoma will worsen, but it will not spread and you are going to have reasonably good prognosis. So in photophobia, again, we want to know whether it's a generalized cone dystrophy or a macular cone dystrophy, or is it a rod monochromat. So all these patients have photophobia, and the ERG helps us to delineate which area is there. And then, of course, as I said, there are other conditions of photophobia which, you know, you may help to exclude. Now here we have a patient who had trauma, and he has a large macular scar and has cataract and wants to know, should I get my cataract surgery done? So I told him, no need to get cataract surgery done because you will not improve. So patient went to some other surgeon who was smarter than me, got the cataract surgery done, and has 6/9 vision. And then he came back and he shouted at me. And then I did a multifocal ERG, and he was right. You know, he has an area of fovea from which he is seeing 6/9. Although adjacent to it, he had a big scar. So if I had seen that before, I would have been smarter. So here we have a patient of BRVO. Now BRVO, we don't need to do multifocal ERG, but this patient has a repeat BRVO. This is old BRVO lasered, now has a repeat BRVO, dense hemorrhage in the fovea, is very worried. You know, he's one-eyed patient, will I recover my vision? So, you know, I can do an OCT to see edema, but I do the multifocal ERG, and it is showing me that behind that hemorrhage, there is very good function. Because if I do FFA, I cannot see the ischemia there. Maybe in OCT angio today we can see. But FFA will not tell me whether he has foveal avascular zone enlarged or not. But the multifocal ERG telling me that it's normal, I can reassure the patient in 4 to 6 months the hemorrhage will go away and he will recover vision. And of course, this patient got back his 6/9 vision. So of course, ERG is extremely sensitive for you know, picking up a patient of diabetes who's going to proceed to NVD or in ischemic CRVO, and of course in ocular ischemic syndromes. So these are very, very sensitive tests which are more sensitive than the invasive FFA or even your OCT angiogram, which you can't do in the periphery. But this is a non-invasive test which never speaks lies. It shows significant ischemia very easily. Now in CRO, we don't need to do ERG, but in transient CRO, it helps. Or in a patient like this pregnant woman coming with a, you know, something like choroiditis, when we did the ERG, we knew that this is an old CRO and an exudative detachment of pregnancy-induced hypertension. So some of these tests can help. So I think a complete evaluation before ordering the test is important. We should do the office procedures before ordering the test. We must know what is the question I'm asking, and then we should know the pre-test probability of getting an answer, and then only we should order the test, and then think in our mind, what do we expect and how we can look at it. So thank you for being here, and the treat we are giving is a printout of the ICEV, it is just hot, it's just published last week, of all, you know, what test to order and how to interpret and what is the role of electrophysiology in your practice. So that's a very, very useful article. It was, you know, written over last 3 years by global people. I'm very fortunate to be one of the few Indians on that. And so Tapas is giving that, and also a handout of some of the slides. And as I said, all this material is available, at least from my presentation, in the textbook of LC Datta and also in HV Nima's book. And if you have any queries, you can write to Tapas or to me, and we'll be very happy to help.
So thank you, Dr. Jalali.